Good evening. Your time now is 5:52. I'm Jeannette Reyes.
And I'm Mona Abdi, and this is Off the Record.
Not for real. This is Off the Record. GLP-1s are the magic drug. This is the thing that we have been waiting for decades. Is it as simple as that?
This is not something that you want to take lightly. It is a real intervention that has real risks.
Dr. Darien Sutton is a board-certified emergency medicine physician and ABC News medical correspondent, known for translating complex medical issues into accessible, relatable conversations for his audience of over 2 million on TikTok.
Serena's really pushed it back into the headlines when it comes to Ozempic and GLP-1 medications.
Yes, I am on GLP-1s and I am going public. I am on GLP-1s and I'm not ashamed to say it and say it loud.
Some of the girlies are making a comeback because we're noticing that they are significantly thinner.
If you're skinny, you're healthy. If you're fat, you're unhealthy. Both of those assumptions cause harm.
First, let's start with how often do people take it and how exactly are they taking it?
So one of the ways is it decreases food noise. It's this concept of the constant chatter in your brain about your next meal.
Does Ozempic affect your sex drive?
You know, it's a good question.
Who is like an absolute, you have no business taking this drug?
Is this something that you're going to be on for the rest of your life?
When we take patients off those, or when scientists take patients off those medications and see what happens, weight gain happens. They find that they gain up to 2/3 of their weight that they had lost. In different cultures, there are different body shapes.
Because being skinny is not desirable in the Somali culture.
I can speak for Dominicans. It's very much the opposite.
So you can be thick and cute, but if you find that it's affecting your health in a negative way, then you should talk to a doctor about it.
True or false, we do not know all of the negative effects of Ozempic.
Dr. Darien Sutton, welcome to the group chat.
Thank you. It smells nice in here.
Oh, good. I'd love to hear that.
We have been really fighting to get you on here.
Yeah.
And I'm so happy
honored
that we made it happen. Obviously, we used to work at ABC News together. You're ABC News medical correspondent and also an emergency room physician. All around just amazing person. You have so many other hats that you wear, so I'll let you officially introduce yourself as well.
Well, so happy to be here, Off the Record. This is, first of all, such a great name. My name is Darien, Dr. Darien, as people aptly call me, and I
will never just call you Darien, by the way.
I know, it feels so strange when people say doctor in front of it and I'm not in scrubs. I'm like, where are we going? Why don't we relax? But I started my career just educating people at the bus stop, creating this thing that I used to call on social media Bus Stop Med, where I would just think about teaching the things I was learning in the hospital to everyday people on the street. And I realized that was something that I loved. And somehow, some way, 10 years later, that has shaped into a career of medical education now on national platforms. And I'm proud to stand in it.
It's so timely because it's happening at a time where there's so much misinformation, disinformation that can be harmful, particularly in the medical field.
Absolutely.
Ozempic has been the latest kind of headliner. It's funny because Mona and I were actually thinking about talking about this last year.
Yeah.
And when it didn't work out, we thought surely things are going to die down. And a year later, right, Serena's really pushed it back into the headlines when it comes to Ozempic and GLP-1 medications. So first, I just want to talk specifically about GLP-1 medications. What in the world is that? Why is everybody talking about it?
I think it's so helpful that you broke it up in that way because, yes, you're right. I felt like there was a moment when it first came out and everyone was talking about it, and then it kind of died down in a way. But if you look at the statistics, approximately 40% of the American population is obese. Close to 70% is either overweight or obese. So it's likely that a treatment option, which can help people with their weight management, is going to continue to grow in popularity. So this class of weight loss medications, because there are many classes, and I'll get into it, but the research around this is actually quite diverse. But the main class that has gained in the most popularity is the GLP agonists. These are simply medications that interact with hormones in the body that result in weight loss. And they started being used about 20 years ago. Near 2005, I think the first GLP product was approved, but at that time it was just to treat diabetes. And during that progress, they saw as a side effect, weight loss was occurring. So then that led many people to asking the question, what is going on here? And they found out that the receptors that this medication is targeting for diabetes also resulted in weight loss. And we found out that there are many different types of body cells or cells within the body that have that receptor and are likely the reason why we're seeing not just outcomes in terms of improvement in diabetes and weight management, but now as more studies come out, understanding how this reduces the risk of cardiovascular disease. And even as simple as something as complex that can lead to more problems like sleep apnea. And so now I think every day, almost like a deep sea adventure, we're learning about the body, how it relates to the syndrome syndrome of metabolic disease, which includes things like obesity, high blood pressure, and high cholesterol, and how patients are benefiting from it in different ways.
Yeah. So Jeannette mentioned it, and Serena kind of pushed this conversation back into the spotlight, even though it hasn't really left the spotlight.
Yeah.
I feel like in different capacities we're talking about it. But I actually was very surprised about the reception because y'all know me, I run straight to the comments. And when I opened up the comments, I was thinking, and maybe these are my own biases, but I was like, oh, Serena, someone who is an exceptional athlete, right, is using this. I felt like people would think, oh, as a celebrity, you're pushing it. Maybe this is the easy way out. And mind you, I've done stories on Ozempic. So I understand the necessity or GLP-1s. But when I opened the comments, I was very surprised that people were like, thank you. Thank you for, number one, being transparent about it. And number two, if someone like you who works out 1 million times a day and is a world-class athlete still is struggling to lose weight, then hello, the rest of us are struggling, right? So were you surprised about the reception?
No, because I think that as a physician, I interact with people and I hear their personal real stories, and it helps me to get a better understanding of the reality of what obesity looks like, what gaining weight looks like, and how for many people it is not a simple thing of choice. I think that historically we've always said, well, it's obviously something that you are doing. You're obviously not working out enough. You're obviously eating too many calories and you're gaining weight. And while that is basic math that leads to gaining weight, weight gain and obesity are so much more complex than that. They can be secondary to not just what we eat, but also the environment around us, the access that we have. Some people simply don't have safe spaces even to work out, and I think that has to be acknowledged, to the food that we have access to in the grocery store. You know, when we see rates of poverty rise, we see rates of obesity rise, and that's not because of gluttony. That's because people don't have access to nutritious sources of food, and so that's one component of it. But then there's another biological reasoning behind that. There are some that have conditions like polycystic ovarian syndrome, a very common hormonal condition that exists among women, where a side effect can be gaining weight. And there are some patients who are taking medications to treat other syndromes where a side effect of those medications is weight gain. And so I think now we're starting to understand that obesity in and of itself is a complex chronic diagnosis that is often relapsing. And if we continue to try to just simply say it's a matter of choice, we're not going to treat it at its root cause. So I think as being a good physician is trying to make sure I take a step back and take myself out of it, which is what I encourage everyone to do. Because the minute you hear people talk about weight management, you'll hear people say, well, this is what I did. And it's like, okay, thank you. But that's not what someone else can do or might have access to. And instead looking at it from a 1,000-foot perspective and realizing, oh, wow, this is so much more complex than I ever initially thought.
It's interesting because when you hear that, one might say, well, then GLP-1s are the magic drug. This is the thing that we have been waiting for decades. Is it as simple as that? I know there have been some concerns about, hey, guys, decades from now, we might realize the cons far outweigh the pros.
You know, I think looking at any intervention as the simple fix of a complex problem, such as obesity, I think would be very naive. And so for me as a physician and a scientist, looking back and understanding, well, what is the root cause to the rising rate of obesity within the United States? Now, that in and of itself is a complex discussion that we could have a whole separate TED Talk podcast about, because in terms of access, in terms of the social determinants that lead to the outcomes of obesity, but in terms of understanding the metabolic syndrome, I don't look at it as a simple silver bullet. I do look at this class of medications, however, as a puzzle piece, a missing puzzle piece to the complex picture that is that metabolic syndrome. And now, like adventurers into the deep sea or space, we're actually realizing that there are parts of the body we just didn't understand how they worked. And that's what the purpose of research and technology and studies are, to understand these parts. And so I do believe, although it's not a silver bullet, I do believe it is a big missing puzzle piece to the clue of obesity and the metabolic syndrome that surrounds that many scientists have been trying to understand for decades.
Is this first like a lifelong drug? If you're on it in order to manage your weight, if you are someone who has, metabolic issues and can't seem to lose weight on their own, is this something that you're going to be on for the rest of your life?
To understand obesity, number one, it's chronic often, and it is often relapsing. And I think sometimes people look at these medications as a simple fix. Like, I just want to fit into this outfit, or I just want to make sure that I can lose this weight so I can keep it off. And while that is possible, because obviously with significant interventions outside of this medication, because it's meant to be used in conjunction conjunction with other lifestyle changes in terms of nutrition, movement, and continued monitoring with your physician, we do see that when patients come off of these medications, when we look at withdrawal studies, when we take patients off those, or when scientists take patients off those medications and see what happens, weight gain happens. And so in certain studies for semaglutide or semaglutide, the active ingredient in Ozempic, when they take the medication off, or patients off the medication, they find that they gain up to 2/3 of their weight that they had lost. And the same thing that they see with tirzepatide, which is a similar GLP, but in the same picture, and it's the active ingredient in Zepbound, patients gain weight. So that tells us that, number one, obesity, yes, it is relapsing and it is chronic, and these medications seem to only work while they're being used. And so if you are looking for sustained, continued weight loss, it is likely that you're going to need some type of intervention. Is that going to be a GLP for the rest of your life? Possibly. Is that going to be a GLP and then maybe new medications that come out in the future? Possibly. Or is that going to mean that you change, you're able to get yourself back into the gym, you're able to be more mobile, you're able to have more self-confidence, and you're able to enact some of those interventions in your life that you weren't able to do before you lost that weight, and now you're using those interventions as a way to keep that weight off. That is also possible. So all of those outcomes are possible.
I kind of want to roll things back just a little bit, because I know for me a year ago, I didn't know much about Ozempic other than I would see people who would drastically lose a lot of weight. So I really want to get to the root of, like, how often are you taking it? What, like, how do you give it to yourself? And then talking about how it affects like your satiety, like how much or little food it takes to make you feel satisfied. So first, let's start with, how often do people take it and how exactly are they taking it?
So there's different types of interventions in the class of GLPs. The most common are the injectable medications, and mostly those patients will take them on a weekly basis. But depending on what that person's needs are, they might have different doses. And some patients might say, I will do every other week because I find that I'm able to weight manage better that way, or it reduces the side effects that I might have from the medication. And then what was your second question?
And so you're taking it once a week.
Yes.
Does it reduce your appetite? Does it make food less enjoyable?
Great
like
question.
what is it doing there?
So the GLP receptor has a lot to do with how we respond to food. One of them being satiety, or the feeling of fullness. And they found that this medication will make you feel more full after you finish eating. I think more interestingly, it also reduces, in some studies they found in many cases, this concept of food noise, which is something that I live with as a person. And it's so interesting because my twin brother, who lives right across the street from this, by the way, my twin brother, he
who's
doesn't
an amazing
have food.
doctor
Yeah,
himself.
I mean,
Like your
beautiful.
parents.
Oh,
I would
thank
not
you.
want to be in this family.
No.
Thank you. Oh my gosh, thank you
Who's
so
just
much.
as handsome.
Oh my gosh.
Just as amazing. Like,
Yeah,
what?
yeah. I know your
Digress.
mom
Mama. Sorry,
loves to
tell
tell everybody about y'all.
I have
I'm just
to plug
kidding.
y'all
Thank
in.
y'all so much.
What?
Yeah, so nice. He loves podcasts, so maybe we'll bring him on
Please.
because
Yes.
he could talk about maternal health.
Yeah. Sorry, we have a whole story
I
on
got
that.
so excited about my brother, I completely forgot what I was talking about.
So satiety.
Oh,
and,
satiety, yes. So one of the ways is it decreases food noise,
Yeah.
which is many who have it know what it is, but might not have a name for it. And it's this concept of the constant chatter in your brain about your next meal. And some people don't have that. And when I bring up my brother, he is someone that doesn't have that. And by that I mean, when we're eating breakfast, I'm like, so what are we having for lunch and dinner? And my brother's like, what are you talking about? And I'm like, you don't have this constant thought and drive to eat that you have to fight against? And my brother's, no, I don't. And I think it's so interesting because we are twins. We've had the same life. I myself have had significant issues with weight management, really working on making sure that those interventions stay consistent. I've also had the privilege of having access to weight management, and so that has allowed me to stay consistent. But my brother has really not needed that. He's never had this food noise concept. He's never had an issue with weight, and we were born on the same day and the same metrics. So I think there's one concept of that, and then it also does this thing called gastric emptying delay, which means that it slows the rate at which food leaves your stomach, and that leaves you feeling more full. But more interestingly enough, it also has to do with how we respond to food in terms of your cues for example, when you really see something that you love. Like for me, a grilled cheese sandwich is like, oh, I'm already salivating. I'm thinking about it. And when I'm having it, it is almost like smoking a cigarette. Those reward pathways, I would assume I don't smoke cigarettes. Those reward pathways in my brain are triggered and that delight is stimulated. And for many people, their association to food in that reward pathway is decreased when they take these medications. And so those are some of the ways that these medications work.
That was one of the most profound things that I learned when I was doing a story on Ozempic, when the person that I was interviewing, the woman I was interviewing said, it shuts my mind up.
Yeah.
She goes, my mind does not stop talking about food, or like, hey, there's cookies in the pantry, there's this. And I was like, I've never heard those. Like for me, I always say I eat to live, not live to eat.
Yeah.
And my sister is complete opposite, right? So we'll go on vacation and it's like, we're at breakfast. She's like, so where are we going to lunch? And I'm like, ma'am.
That's why you and I can't be together.
No,
Because we're
like
very
we will
similar
sit
in
here
that
and be
respect.
like, I had a coffee
Same.
today. And it's
Breakfast.
not that I'm trying to avoid food.
Yeah.
It's just, it's not on my mind.
Yeah. Some people who were like, I was so stressed I didn't eat today. I'm like, that couldn't be me.
I do wonder too, because doesn't it also, when you're eating, you get, I don't know what the term would be, kind of like this
dopamine
trigger. Like, yeah, like it's just, it lets you know, okay, you're full, you've hit your limit, you're good. People who struggle with that limit, they can bypass that essentially. And the GLP-1s help with that. When you talk about though, like it affects the reward system that you have, I wonder if that also spills over to other things that bring you delight and pleasure and reward. And I'm reminded of this because you mentioned working out, other things, like does it just affect your desire to do things that bring you joy?
You know, I think although my hypothesis is yes, there are studies that are ongoing to better understand this, because what they found was that with patients who were using these medications, they would come back and say, not only have I lost weight, but my desire to drink has gone down. My desire to gamble has gone down. And so we start to understand, number one, the brain is so complex and there's so many overlapping wires to how we reward ourselves. And we've realized that maybe this medication is helping not only with your association of reward to food, but your association to reward of other things that you might have a use disorder with. And so now they're studying how these medications can affect those who have alcohol use disorder or other substance use disorders. And they're finding that there might be a benefit there. But I think that there is still more time and larger studies that are needed to like more succinctly answer that question, because it's complex.
I was going to say, hopefully I'm not asking the same question, but does Ozempic affect your sex drive?
You know, it's a good question. I'm not sure. I think it's because sex drive is also so complex, right? Because sex drive is associated to a reward pathway, but then there's also a feeling that, a self-confidence feeling, and there's a lot tied into before you have sex and how you feel about yourself. And so I think that this is, that answer is not easy to answer, even from a scientist's perspective, if you were able to do a study, because there's so many things that go into your sex drive. But
like
possibly.
more confident about yourself, and you might want to have more sex.
And there are some people that are able to have sex quickly and easily, and there are some people who aren't. I think that's also displaying how complex that is as well.
I'm curious, if you eat a lot of food as comfort, let's say you're depressed and you turn to food when you're going through a rough patch or you're depressed, when that is taken away, the delight that you get with eating food, do you turn to something else once you're on an Ozempic and that kind of thing to give you that comfort, whether it's alcohol, whether it's gambling? Do you see what I'm saying?
Yeah. You know, the idea of a new problem or compulsion being created when you've decreased or eliminated one is one that is constantly asked in science. And I don't think that, and I'm using data and evidence, I have not seen an outcome where those who have eliminated one use disorder or a compulsion have begun another. But we're now beginning to discuss obsessive compulsive disorder, which is its own psychiatric diagnosis. And I'm sure that patients who have a true psychiatric disorder that is associated with compulsion might need more interventions beyond just discussing GLP medications.
Yeah.
I do want to know also about some of the maybe like cultural conditioning around food. Because I know in my family, you are not getting up off that table unless you eat seconds and thirds, or it's an insult and you finish your plate, right? Because then you're insulting the host, right? So when that's the case and food is seen as like, no, you need to eat even after you're full, and you've been taught that wasting food is disrespectful and that there are people without food, and here you are, it's a privilege to be able to finish your plate. How do you work through that while now you're trying to obviously use some of these medications? I think
that probably is one of the hard parts of many people's lives that they change. I think if you started a medication that decreases something that you love, it is inevitably going to change the culture around it. And we're already seeing that on a grand scale. You know, we're seeing companies dial back certain food products, companies trying to respond to the craze of Ozempic by creating products that people might be find more palatable and be more easily consumed when they know that patients have less of a drive to eat. And I think that question about how it changes the culture around food individually and also from a family and larger population perspective, I think it very much will. We're already seeing the signs of that. And I think with ongoing progress into the future and our understanding of weight gain, weight management, and obesity, I think that unfortunately for many, it might change what they find love in. But with that being said, I think it's going to open up new opportunities for many people in terms of understanding how they interact with food in general.
Because being skinny is not desirable in the Somali culture.
Yeah, I can speak for Dominicans. It's very much the opposite, which is it's so interesting because I saw that kind of conversation happening under Serena Williams' post in the comment section. Like, man, we liked her thick and curvy and this, that, and the other, and she's losing weight. Like, girl, what are you doing?
Yeah.
Which is, it's so interesting how in one culture this is the goal, and the other it's like, you look sick.
Well, we have to separate from that too, because even the dogma in medicine was initially, at least what it felt like, was if you're skinny, you're healthy. If you're fat, you're unhealthy. Both of those assumptions cause harm because you are missing the patient who has cardiovascular disease, metabolic disease, and is theoretically skinny. And you are focusing on the person and stigmatizing the person who is overweight because you are associating their weight with immediate direct harm. And I think that as a physician, it's really important to recognize the bias that you had outside the hospital before you walk in. And if you're using evidence, you would realize that you really just simply can't look at a person and diagnose them. You have to understand them on a better level. And I think that comes to a cultural perspective here, because in different cultures, there are different body shapes. And the concept of how we develop BMI or body mass index really was focused on one culture. And we use that in the many ways that we use culture, and we applied that to everyone. And then now we're looking back and we're saying, wait a minute, different BMIs can exist and people can be metabolically healthy. So I think that it really touches on how we, and my family at least, I come from a family where people used to call it big boned, and this concept of you're thick. And I think that there's beauty in that, and understanding that that can exist and you can still be healthy. But when you are going through the metrics and making sure that you're going through the screening processes, if you're finding that you're dealing with things like insulin resistance, or you're having problems with other conditions, or you're having difficulties with mobility, now it's affecting your life in a negative way. And that is when I think it's important to address it. So you can be thick and cute, but if you find that it's affecting your health in a negative way, then you should talk to a doctor about it.
I'm curious, we've talked about who essentially qualifies for an Ozempic or a drug of the sort. Who is like an absolute, you have no business taking this drug?
That's a great question. I would love to say and I think this happens when you see people who are, in your mind, someone who might not have a significant amount of weight on them, and you're saying, well, what are you doing it for? You know, number one, I always try to remind myself, Darien, it's not your business. Secondly, I always try to say to myself, you realize that, for me at least, there might be people who are taking it because they want to reduce a risk of cardiovascular outcomes or a risk of sleep apnea, things that we've seen that have benefited from these medications. So there's no specific person who can't be taking it. I think that what is really important and what concerns me are the people who take it without being monitored, the people who take it without being screened, because I think that increases your risk of adverse outcomes or negative outcomes where you'll land in the emergency room with me because you bought this from a source where you can't verify and you're not following your numbers appropriately. And now you've caused yourself harm by looking for an easy way out. And that is what I get most concerned about.
Because listen, when it comes to the world of celebrity, some of these women, I know they're like, oh, celebrities are abusing it or whatnot. But then you see some of the girlies are making a comeback because we're noticing that they are significantly thinner. They maybe feel better about themselves and now they're out in the open. But is it harmful to see kind of like your favorite celebrity get back down to a size 0 and see that it's kind of prevalent and widespread in use in Hollywood?
Well, I think that our depiction of fame and celebrity on large platforms often distracts or takes away from the reality that people experience and makes them believe that there's something that they're doing wrong. And when you see your favorite celebrity all of a sudden lose weight, then in your mind, I think we're naturally drawn to wondering what we can change about ourselves or how we can emulate that. But as people who have platforms, we all know that people they think they might have a parasocial relationship with us, but they actually have no concept of what we're doing in our normal life. They don't know what we do when we work out. And I experience that as a person with a large platform. So when I'm looking at a celebrity with a large platform and I see a specific change, I remember I actually have no idea what in the world that person is doing.
I do remember that reminds me of the time pre, GLP-1s when we were like, how are all of these celebrities losing weight so quickly?
Yeah.
They look fabulous.
Yeah.
We need to go on an even stricter diet.
Exactly.
You know what I mean?
Yeah.
So I do think the upside is that there are more conversations. Like I think if Serena would have talked about this last year, it would have been earth-shattering. There was a little bit of prep and a little bit of kind of like conversation leading up to her announcement where she's just now another celebrity, except that she's a world-class athlete. You mentioned some of the cons, particularly for women. I've heard about losing some of the good stuff that you do need that's also helping you lose the weight, which is, bone density and lean mass. Is that accurate? And is that something we should be concerned about?
When we talk about this too as well, with the concept of the importance of monitoring patients while they're on it, this is not something where you, like any medication, if you're prescribing a treatment for high cholesterol, if you're prescribing a treatment for diabetes like insulin, you're going to inform that patient of the benefits. You're also going to remind them of those risks, and you're going to remind them of the necessity to keep up with making sure that they're continuing to monitor. I think when you look at some of the outcomes, in certain studies, there have been reductions in body mass or muscle mass. In certain studies, there have been hair loss. And I think when you look at those outcomes, yes, they're possible. But they are likely associated to just possible side effects of this medication that I think should be monitored with a physician. And if you notice those symptoms, you can address them. So I don't know if it's every single person has that experience. It certainly has not panned out that way in science. But the most common symptoms or side effects associated with these medications are gastrointestinal symptoms like constipation, nausea, diarrhea. Those are the most common. And then the second most common are outcomes like pancreatitis and problems with your gallstones. And these often present as abdominal pain. And as an emergency physician, if a patient is on these medications and comes in with abdominal pain, I'm going to be more inclined to wonder if they have one of these complications. They're not as common, but they're important to know about. And then there are these rare outcomes that we're trying to understand. Now, with all of that being said, you have to weigh that against the benefit of an intervention.
Right.
And so if you are having a difficult time managing your weight and that weight is causing you to have associations with inflammation, reductions in your responses to hormones, and leading you to an increased risk of cardiovascular disease, heart attacks, strokes, and even dementia later in life, and you want to address those urgent health concerns, you take that with the possibility of the risk, you weigh that balance, and what that equation equals and what you feel comfortable with is what you should go with. Does that make sense?
Yeah.
It does, and it actually makes me wonder, if someone tells you, I'm on high blood pressure medication. We're like, oh, okay. You may have to take it for the rest of your life. Oh, okay. I'm on high cholesterol medication. Oh, okay. I'm on Ozempic. All of a sudden now there's this like morality police come out and they're like, you should get in the gym and do it the hard way. But we never say that when it comes to blood pressure or cholesterol. I'm
so happy that you brought that up, because of our relationship with obesity as a society needs to be redefined as we learn more. And it's so funny that you say that, because if someone has high cholesterol, yes, as a physician, I would like to remind you that eating saturated fats and salt and sugar are going to increase your risk. And while I want to make sure that you have a lifestyle intervention change, if your cholesterol is really high, it would be inappropriate for me just to say, good luck, figure it out, without giving you an intervention or offering you one that might benefit you while you change those lifestyle interventions. And I think that same conversation is had with obesity. Hey, you're having a problem with weight management. I notice that your numbers are going up and I'm concerned about your health. I would like to remind you that this type of nutrition, this type of movement, and this type of monitoring can help you. But while you're doing all of that, there's also interventions that might be able to boost that path or boost you on that path. And I'd like to let you know about them. Here are the benefits, here are the risks. That is how an appropriate clinical conversation about a problem should happen. And instead, I think we apply our own business into people's business. And then we say, well, why can't you just do it yourself? And that is because of our bias associated with obesity rather than understanding about about specific medical conditions that most of us who are not physicians and many physicians are not fully aware of yet.
Yeah, and I think it speaks to something that we as a society struggle with a lot, which is one, nuance, and two, it doesn't have to be either or.
Exactly.
You can do two things at once.
Exactly.
While you're taking the GLP-1s. Really quickly, I did want to ask you this. This made headlines a while ago. Do GLP-1 medications affect the effectiveness of birth control?
That's a great question. And that has to do with weight as well. Because if you're going to take a GLP medication, your weight is going to change. And your birth control, for many don't realize, is often weight-based. And so that might be the relationship there. And so although there might be an association, as we always say, it's not necessarily a cause and effect.
Correlation
So
is
we
not
have to look and see,
causation,
what is the relationship here where people are losing weight, their fertility is changing, and then we need to have more conversations about how to manage that. So that is very possible. But I know that many people who are on birth control may not realize that birth control itself is weight-based. And when you're having a conversation about birth control, you should include your weight in that conversation if you want to make sure that it is effective.
So I kind of want to go back to the conversation about BMI really quickly, because I know that when you look at the statistics, Black women are because of the BMI index, are seen to be at more obese, I guess, percentage-wise, than other populations. So I want to get into that, because how much of that is based on BMI, and BMI being based off of maybe not necessarily a diverse group of people.
So BMI was created by a math statistician, someone who was not really in healthcare, who was trying to just understand populations and trying to use it in a way where they were able to identify changes within a population. It wasn't really initially meant to be applied to someone's individual health. But through time, I think many people, through ease of calculating it, has used it in a way where we can try to define people who are high risk. And with that being said, we've kind of forgotten, as many problems in medicine exist, where we've forgotten, who was this study originally done on? Do the people who the study was done on look like the people we were talking to? And that's an important concept in science, where you're applying, making sure that the science behind the data is diverse so that you can apply it to a diverse population. And so what we found is that for Black women specifically, they tend to have higher BMIs than their white peers. But does that translate to poor health outcomes? And not necessarily. There are studies that show that Black women or women who have higher BMIs can be metabolically healthier than their white counterparts who have lower BMIs. And I think it's about also how we hold weight. We know in medicine now that holding weight in different places of your body creates different risks. And so for those who might hold weight significantly in their abdomen, we know that that is a significantly increased risk of cardiovascular disease compared to women who might hold weight in their hips, their waist, their butt. And so I think that's a really important discussion to have, and understanding that it's not just about how much you weigh, it's about how you hold weight and also your metabolic health. And all of those factors can be different and so much more complex than a simple math equation.
You're very big on social media, and I love the way that you break complex things down for people, and your mission is to educate people. And
Absolutely.
I love that you take the time outside of your very, very
and
busy
it takes a lot of
schedule, guys.
patience, because
Yes.
there's a lot of other fellow doctors who are not really doctors on social media that you're dealing with.
Doctors.
Yeah, so we've seen them all.
Yeah. What are some of the questions or the conversations or
Yeah.
even myths that you want to bust right now?
I think, since we're on the topic of obesity, just simply reminding everyone to take a step back and mind your business. I think that's number one.
Mind the business that pays
Mind your
you.
business.
Okay.
I think it's so important, because there is so much that goes into someone's weight that is so much more than what you believe. And I think we have a difficult time as a human species not quickly imparting our own experience onto someone
Projecting.
else. And projecting.
Yeah.
And I think that happens so often with obesity, and it's so tolerated when we have fat phobia and fat shaming that is so widely accepted. And we never took a moment to reckon with that before we began the discussion of treating obesity. And so now we're trying to treat obesity while allowing all of this fat phobic rhetoric continue to play out. And I think as humans, we have to realize, like, oh, we're part of this problem. And then also understanding that, again, weight and obesity are so much more complicated than anyone can ever imagine. And we talked about this before we started this podcast conversation, but there are choices that are made before people can even make their own choices. And if you want someone to go on a calorie deficit and work out 3 times a day, try to do that when you're working a 12-hour shift with 2 children at home who you also want to make healthy meals for, while making sure that you're keeping some level of sanity for yourself. And if you're going to do all of that, how are you going to do a calorie deficit if you don't have time to work out? Then are you asking people to starve? Yeah. So I think with all of that being said, realizing that people have different constraints in their life that might not allow them to do the things that you can do or that I can do. And you, again, have to take a step back and mind your business.
I love that.
To reiterate Mona's question, I am curious, what is the biggest misconception you've heard about GLP-1s?
That they're a quick fix. I think that GLP-1s, number one, the average amount of weight loss for those who take GLP-1s is less than the drastic changes that we've seen. We see drastic changes because I think that people who are platforming these have significant privilege in the interventions aside from GLPs. And so their change is probably so much bigger than what people will experience. About 15% of people who use GLPs don't respond to them. And so that can make people feel very, very isolated in a way, because again, the human bodies are so different. And so just like there are a variety of different blood pressure medications, and some of my patients who are on the same type of blood pressure medication will continue to have high blood pressure, that's because their body isn't responding in the way that others will respond. So I think that's the biggest part here that people don't get, is that we all respond differently. If you have a history of pre-diabetes or diabetes, it's typically more difficult for you to lose weight even on these medications, which is why we see a 5 to 10% less weight loss with those who have diabetes. So I think the biggest misconception is that once you take it, you're going to immediately see the outcome that you've seen on television, and that's not the reality.
I do have a question about just the psychological component of this, because weight loss can affect a lot about how you see yourself. And for some people who maybe have gone through bullying because of their weight, who all of their life they've been considered overweight or obese, to then hit their ideal goal, for example, is there anything to help them deal with that? Because it's like the medication is doing its job, but then when you look in the mirror, you don't recognize yourself, or you see people treat you differently. How do you deal with that?
I think really enforcing and reminding people the value of psychological awareness and psychological treatment. I think seeing someone and talking to someone, especially if you're going through this, is a wonderful addition in terms of your treatment. Getting to the root cause of your problems with weight probably don't just involve a medication. They probably just don't just involve a calculation on how many calories you're eating, but there's also a psychological component. Food is everywhere. It is a lot easier to stop smoking when you tell people that you're done smoking because you have a problem with smoking. Everyone accepts it. But when you change your relationship with food, that is very difficult for people to understand. And so I think that requires sometimes assistance in a psychological way, where you need help managing those dynamics, because it is very difficult to avoid food as it is, for example, alcohol or cigarettes. These are very different problems, but they lead to similar outcomes. And so I think talking to people about how you're managing it, and talking to someone who has some level of certification, who is trained to help you with that, is probably the most important.
I'm curious, obviously GLP-1s have been a game changer, but 20, 30, even 50 years from now, what is, I guess, essentially, what's the next frontier? What are we going to look back and say, oh my gosh, we thought GLP-1 was killing it. You know, this thing is incredible.
I think it's so interesting because I personally think that the future of weight management is we're going to look back like we do all of the science, and we're going to say, what in the hell is going on? And I think when we think about the different ways that people lose weight, I wonder if surgical gastric bypass will become a thing that becomes like, wow, I can't believe we were doing that.
Stomachs,
You know, I wonder, it still can benefit people, because there are certain people who can't take GLPs, for example, or that's their only option. So I'm sure it will still be around, but I do wonder how we will look at it. The actual research pipeline for weight management is incredibly diverse, and it is booming. And it's not just GLPs. There are at least 10 different GLP pill options that are currently in process and likely will be approved by the end of this year. For example, Novo Nordisk has already submitted their application to the Food and Drug Administration for their oral Wegovy pill. That's a pill that, if taken once a day, they found that has comparable benefits in terms of weight loss compared to injectable medications. And if that's approved, it could be available as early as this year. And then there's also a pill from Eli Lilly that they've currently completed their phase 3 clinical trials. Now, this is the part of the clinical trials where they're making sure that there are consistent responses across a diverse population, and they found that weight loss was similar to injectable medications. And if they submit their FDA application, there might be 2 oral options of GLP medications available as early as next year. So that is something that I think is on the acute or very current horizon. But with that being said, I think 30 years from now, we're going to be looking at a lot more of a diversity in the options where patients can take to treat or help with weight management in the same way that we look at blood pressure. When I'm prescribing a blood pressure medication, there are dozens of different types.
Yeah.
We tailor the type of medication that we prescribe to the patient's needs, and I wonder if weight management will also go in that direction.
My local med spa is offering Ozempic with a Groupon.
Yeah.
Do you trust that, or would you recommend?
You know what I'm going to say.
Yes. But I just got to know, because the Groupon was looking real
My
good.
sister's auntie's cousin was also selling it too. So.
You know, a Groupon to do anything about your health, I'm definitely skeptical of. So I would say making sure that you take it with a grain of salt. But obviously, there are some people who are really, I can understand it, looking for that option and might only have this specific access. I want to remind that this is a real intervention. It comes with real risk and requires real providers who have a certification to be able to prescribe it, monitor it, and follow it. I am a correspondent. I don't consider myself an obesity specialist. I wouldn't feel comfortable prescribing it to a patient.
Gotcha.
And with all of my accolades, with all my education, I'm telling you that honestly, and I hope that people realize that. You know, this is not something.
I'm not gonna lie, I thought you were the plug.
This is not something.
I know, right?
This is not something that you want to take lightly. It is a real intervention that has real risks, and so you want to make sure that you're talking to someone that you trust that can help you in the event that you need assistance or you have a problem with it. It's not something to be taken lightly.
It's so crazy to me, by the way, how this has just entered like the zeitgeist, how people can talk about this fairly like formally, like knowledgeably. Because when we say Ozempic, all I think is, Ozempic, which is terrible.
You know
It's so good. What is the other
jam.
one? Wegovy.
Yeah.
God,
No, they're great songs.
They're great songs.
They're
really catchy.
bops indeed.
Only in America.
Like,
Right.
we figured out how to apply a song to a medication. You're right. You're absolutely right.
We did have some rapid fire questions that we wanted to ask you. It's called On the Record. First one, you can stop Ozempic as soon as you hit your goal weight without consequences.
Possibly. And the reason why I say that is if you're a person of data, again, if you stop it, you'll likely gain the weight back if you don't do anything else. But does that mean that you can apply certain interventions at max level that might help you maintain that weight? Sure. But possibly. But not yes or no.
Okay. Ozempic changes how your brain thinks about food.
I think yes. I think that's an absolute yes. I think Ozempic changes how your brain looks at food and thinks about food. And I think many people who are on it will give you really great perspectives about how that changes.
If you stop taking Ozempic, you'll immediately gain all the weight back.
I don't know. I don't think that that's the case. I think that the weight gain likely is gradual. And again, in the studies, it may be 2/3 the amount of weight that you've lost. So you might not gain all the weight back that you've lost, but you will likely gain some.
True or false, we do not know all of the negative effects of Ozempic.
We do not know all the negative effects of Ozempic. We do not know all the negative effects of most interventions that doctors prescribe, but we know the most common. So you want to make sure that you're aware of those, but you also want to talk about what conditions you have historically. What are the risks that you're concerned about for your own health in the future? What are the side effects that you're most concerned about? And then what does your insurance cover? Those are the main questions you want to talk to a doctor about.
Dr. Darien.
This was nice. Invite me on. I talk about a lot of stuff.
Oh my gosh, listen, I'm already like, let's talk about BBLs. Like,
Honestly,
I'm ready.
we'll go there. Yeah.
Dr. Darien Sutton, please tell them where they can find you, because you are a wealth of knowledge. You have me in the surgical room. I feel like
that's so sweet.
scrubbing up while I'm watching your TikTok.
You can find me, aside from Off the Record, you can find me on social media at DrDoctor.Darien on Instagram, and the same across most of my platforms. So yeah, just shout me out, tag me, say hi.
Thanks for coming on. You were great.
Thanks for having me. These chairs
amazing.
are comfortable,
Oh, right.
y'all.
I mean, listen, if you want to
Wow.
chill here for a little bit longer, we got you.
They're at home, they might not know. This place looks expensive.
The next episode, we're gonna ask about dating advice. We're just gonna keep asking you questions.
That's
'Cause
when I really-
we're
yeah.
gonna then bring your mama on and
Oh,
ask
please.
her how
Oh,
she
no,
raised
no. We don't have enough time.
amazing children.
Yes.
Oh, thank you so much.
Thank you, love. I appreciate it.
Thank you.
All right. Thank you for watching Off the Record or listening to Off the Record. Make sure you join us on the next episode. In the meantime, subscribe on YouTube at Off the Record and on Instagram at Off the Record Podcast. We will see you on the next one.